Support for UWTV is provided by the Boeing Employees Credit Union.
Well, it's a pleasure to be here. Thank you for coming, and I hope that I can intrigue you a little bit with some of the stuff that I've just started doing in this, and just finished my first year on the task force, and have started just to really understand it enough so I think I can talk about it. And I think that before we get started, I'll just go through a couple things which I actually have to do on a regular basis at these task force meetings anyway. Is one of them is a disclosure issue. I am employed by Group Health Permanente, which is a private medical group, as you know, in the city. So, and we do follow these guidelines, and we have our own series of guidelines. I don't have any financial industry ties. And the opinions that I speak today, I do have permission from the government, U.S. government, to actually use their logo on the slides. But I should say that my views don't necessarily represent the views of the U.S. government or Group Health. Well, I found these quotes, and I was intrigued by them. One by two very different kinds of people. You know, one by Mark Twain and the other by the physicist Stephen Hawking. Mark Twain said, "It ain't what people don't know that hurts them, what they know that ain't so." And Hawking, saying in a slightly different way, saying the greatest enemy of knowledge is not ignorance, it's the illusion of knowledge. And this is really the kind of the pivot point for talking about evidence-based medicine and why evidence-based medicine is gaining a second foothold in American medicine. It's really about how do we know what we know is really the truth. And what I'd like to sort of share with you today is, as we go through some of this, is about understanding the screening recommendations from the task force, how they're developed, particularly around methodology. And we as a group are trying to become much more transparent about methodology for a number of reasons. To also sort of understand this current screening guideline, the grading system, which has changed. And I think there's a lot of confusion, misunderstanding about some of the grading system that's used, and so I hope to go through that. And then finally, to share with you sort of some of the analytic model approach that we use in order to actually ask the correct questions when we do these recommendations. I also have ulterior motives, and the ulterior motives are really at the bottom of the screen. One is, I would posit to you that I think the task force has become a model for developing evidence-based recommendations and sets an example and a benchmark for professional societies and other organizations doing similar activities. I think that, I hope that you can see how some of these recommendations that I'm showing you have been translated into policy, because as many of you know, it's one thing to make guidelines, it's another thing to actually have them do anything. And in fact, the task force, I think, has been reasonably successful in translating guidelines recommendations actually into true policy. And the final note that I'll leave you with at the end of today is, why is this stuff relevant? You know, how is this going to be relevant to any of us in medicine? Well, I think the drumbeats are definitely there with the new administration around how to approach the problem of healthcare reform, and clearly part of the groundwork that's being laid really relates to evidence-based medicine and decreasing waste, and those two things are clearly tied together. So I'll touch on that on the end. So I'd like to start just by defining what I mean by preventive medicine and clinical preventive services, just to make sure we're all on the same page, because this gets confusing and everyone has slightly different use of semantics around this, and also sort of lay out some what I think are sort of the key myths about preventive medicine that I think are important as part of a disclosure. When I talk about clinical preventive services, I'm really focusing now today on primary and secondary prevention. And by that I mean immunizations, but we're not going to talk about that today. Medications to prevent disease, so aspirin to prevent heart disease, for example, folic acid to prevent neural tube defects. Office-based counseling and behavioral interventions to promote healthy lifestyle change, so counseling to promote physical activity, for example, or counseling to reduce high-risk alcohol use. And then screening, which is really where I'm going to be spending the focus there, because that's what you guys end up, that's the piece of the pie that laboratory medicine has as its biggest foot in, which is really about screening either high-risk people and or low-risk people. But in preventive medicine, we're talking about asymptomatic people, people that have no symptoms and signs, so we're not using these as diagnostic tests, we're using these as screening tests. And I want to distinguish that from public health, which I also play in, but public health is, as you know, is really, it includes all this, but it takes a different population focus, so it's the health department looking at the whole population. But in addition to that, includes much more, as you well know, including environmental health, issues around disease outbreak control. So when we talk about clinical preventive services, we're really talking about those four, in particular, those four areas. So everyone wants to buy an ounce of prevention. And plenty of people want to buy a pound of cure, too. That's not to say that prevention has the corner on the market. But I think that the question is, does everyone really know what they're buying when they buy an ounce of prevention? And do they really understand the price that they're paying for that ounce of prevention? So let me just be, as someone who on a daily basis is that I live and breathe as a preventive medicine person, let me just be the one to expose what I think are the four myths. And this is gaining some, you might notice increasingly op-eds in the New York Times have showed up on this. This month's Health Affairs Journal has a counterpoint on this topic. But there is a general, our politicians tend to have this belief that prevention is absolutely the right thing to do always. And they also, there is a fairly widespread belief that prevention is a surefire way to save the health system money, that early detection always saves lives, and that prevention is always cheaper than the cure. And I hope that, that you can appreciate that, in fact, these are myths. That as much as I would like to say that prevention comes first always, in reality that's not true. And in fact, to deconstruct some of those myths, this is really the way we should think about it. That prevention is the right thing to do when the benefits outweigh the harms, and that the certainty of that net benefit is at least high or moderate, and that the measure is cost effective, which frequently we don't consider, and we can talk more about that later. That's sort of the elephant in the room that no one likes to talk about. Preventing disease with clinical screenings or immunization almost always carries net costs. It's rare to save money with prevention. Now that's not to say that we don't get value back. We do. We get lives saved. We get improved quality of life. We get something back in return almost always, sometimes not. But it's becoming increasingly and vanishingly rare to actually save true money with preventive medicine. Early detection may or may not reduce mortality, but it can induce harm. And harms have always been sort of the underplayed feature around preventive screenings in particular. And then finally, that some preventive screening and immunizations are less cost effective than treatment of the underlying disease itself. In other words, from an economist standpoint, it's not rational. That you spend so much money on the prevention, you might as well just let people run the course of their disease. And of course, that's a whole extended topic in of itself, which I'm not going to address. I think you also know that screening has become a big, prominent healthcare business in the U.S. There are industries that are developed that exclusively do preventive medicine. And these entrenched financial interests promote screening and sometimes inappropriate screening. We can't make assumptions about the value of those preventive services on a standard basis. And the focus of healthcare inflation really has to be, when we try to reduce costs, we really have to understand where that value equation lies. And it's not just about costs, it's about what you get back in return. So one of the purposes of the task force is really to assist primary care clinicians, and that is the audience, it's primary care clinicians, in deciding which screening tests best to use with their patients. And that's what we'll be talking about today. Let me tell you a little bit about the task force in case, how many of you are familiar with the task force already, so I have a sense of that? Okay. The task force are composed of experts in primary care and preventive medicine. They represent essentially the four primary care specialties and include OBGYN as one of those. They also represent people from nursing and also behavioral health. It's government supported by the Agency for Healthcare Research and Quality, AHRQ, which is the main health services research funding agency for extramural grants, but also does most of the work of HHS around quality. And the task force is independent. It's not an advisory committee. Not like most federal advisory committees that report up through the superstructure and ultimately this government's decision. Actually, task force is completely independent. So it's a very different, it's very unique in that way. We're not special government employees. We make the decision. It doesn't get actually vetted and run up through the department. So it creates for an interesting political circumstance. The task force gets scientific support from AHRQ through the AHRQ-funded Evidence-Based Practice Center. Our closest neighbor in Oregon, the Oregon Health Sciences University, has a superb one that's done together with Kaiser Permanente Center for Health Research. And together they do a dynamite job in preparing the evidence reviews. And we also include liaisons from primary care clinician associations, so the major Academy of Pediatrics, family physicians, American College of Physicians, et cetera. And also all the major federal agencies as well. The mission of the task force is to evaluate the benefits of individual preventive services based on age, gender, and risk factor for disease, and then to make recommendations about which preventive services should be incorporated routinely. And routinely is the operative word there. So again, when we're talking about screening, we're talking about screening everyone, not just individual, not the use of diagnostic tests, but the use of, without further information other than age, gender, or demographic information, deploying those tests. And then finally, the task force has gotten involved as of late in helping to define a research agenda around clinical preventive services, because NIH comes to the table, as does, and obviously AHRQ is a funder too. Increasingly, we're able to point out where the gaps lie in our ability to define where we really need to go in order to be able to take a question off the fence. And there's lots of questions on the fence. Task force history started, actually the idea came from the Canadians, like many good ideas. In the 70s, the Canadians actually started a similar thing, and the US Public Health Service started in '84 a similar model. However, very different in its approach, and the methodology in '84 resembles nothing like what we do today. It was in '96 that the CDC convened a parallel task force for public health, and that's called the Community Task Force on Preventive Health Services. And if you look on the web, it's communityguide.org, and they do a great job doing public health systematic reviews. And then in '98, they started the third task force, which subsequently now has been turned into a standing federal task force. Al Berg, who you all probably know, was the chair of the task force from here in family medicine for probably 5-6 years, and stepped down about 3 years ago. So what do? Well, one of the major purposes is really to do systematic reviews of the evidence for effectiveness and also then to develop those recommendations. And the recommendations really go across the board of screening tests, counseling, and preventive medications. We do not do immunizations because the CDC does that, and we don't. There's no need to. However, and preventive medications, I would say, is a relatively minor scope. Screening is the bulwark of the activity for the task force. How do topics get selected? And I'm going to share with you some of the, you'll see sort of the particular recommendations in a little bit, so you have a sense of what it is in the spectrum of stuff we're talking about. But there is a nomination process. If you happen to read the Federal Register while you eat breakfast every morning, not too many people do, but I know a few, then you would find out, actually you would see a particular notice actually calling for nominations of topics. The task force reaches out to the scientific community, to professional associations, the medical community, to ask for good ideas or ideas that are particularly salient or thinking that we need to look into. We get some mostly from organizations. We don't get much individual response, but we get organizations who write in and have particular issues that they think are important for their constituency that they ask us to look at. So in the process of doing that, a subgroup of the task force reviews that together with AHRQ to decide if it meets some of these criteria, to see whether they're within scope, and that includes whether or not it's a primary or secondary preventive service to start with, whether it's relevant to primary care. You wouldn't believe how many actually are not come in that really are not relevant to primary care. And also whether or not they assess diseases or conditions with substantial health burden. Are we addressing important problems, or are these really minutiae things that affect a very narrow slice of the population? And as I talk a little bit today about lipid screening, in particular in children, as one example of this area, I think that, as you can see, that the question might be raised, well, why did that come in as a topic? And I think the major reason that it came in was because of the rising epidemic of obesity in children, the demonstrated the concomitant rise of lipid values among children, and the sense that we know how to treat hyperlipidemia, and therefore we might be able to do something about it. And that was probably as far as it went at the time that it got thrown in. And with ultimately the idea of, what are we trying to prevent here? We're not obviously preventing heart attacks in children, but what we might be doing is preventing heart attacks in adults. And given the magnitude and the scope of that particular problem, it was felt that, that there was probably some literature to look at, that particular topic got under the door. But a lot of topics actually get parked outside the door, or actually not even considered any further. It prioritizes its topic using those criteria, and I think those criteria pretty much follow along what I, in a second drill down, get into these areas. And you know, one of the other things that we're really interested in is how much controversy is there. If there's not a lot of controversy and everyone's already doing it, you know, there may not be a big need to do it, particularly if it's not a significant financial drain on the economy as well. That if there's a big gap between evidence and practice, that's a good one. In other words, if we have a good sense around what the evidence is, and in fact there isn't much going on, the task force can be a bit of a catalyst to help move that along. And then there's some other issues at the bottom here that to try to develop some diversity in the portfolio of things that are there so that it reaches across those various categories, as well as different demographic groups, so that we do consider the interests of children as well as older adults, for example. We prioritize based on three major areas, on 3-point scale, really on those three areas of impact, burden, intensity of resources. It's a sort of semi-quantitative process, to be honest with you, and I think that what it does is it helps to prioritize the review process, because increasingly we're finding that the costs of doing the reviews are such that it's difficult to really, you cannot do everything, and you need to prioritize what needs to get bumped to the top. The other thing you may know is that the National Guideline Clearinghouse, which is where really guidelines now float into, and it's the best place to find guidelines, by the way, it's a great resource, but they will not carry a guideline in it that's more than 5 years old. So that means the task force has a clock ticking on it that needs to, if one of the existing recommendations goes beyond the 5-year mark, it drops out of sight. And because of the importance of that, and because of its embeddedness in a number of different search engines, that's felt to be a really important thing. We want to try to stay in that guideline clearinghouse. Not to mention the fact, of course, just trying to keep things at least 5 years current is important as well. So just to give you a feel, this is these are the recommended services for non-pregnant average risk adults. And you may say, wow, is that all? And in fact, this does not include high-risk adults, which I'll show you later, and it doesn't include pregnant women, and it doesn't include a number of other categories. And these include both the A and B grades, and I'll go through that a little bit more to just sort of help you understand how we get to an A versus a B. But these are recommendations that clinicians are advised to do. And I put in yellow the ones that that interface with you guys. I think I'm right on this. Tell me if I missed something here. But clearly in some of these other, when you look at the entire list, lab medicine actually comprises a fairly significant proportion of the recommendations. So hopefully none of these are terribly surprising to you, and they're a little bit cryptic, so it's not completely understandable, but I think you probably understand most of these, and I'd be happy to talk a little bit about any of those that you want at the end. I'm not going to spend a lot of time going through these individually, because I really want to focus on how we got to this, so that you have a fairly good understanding about what that process is about. So let's dive into the methodology a little bit. We talked, the first step is really to define those questions and the outcomes of interest. When you're doing an evidence-based or systematic review, you obviously can get badly on a wild goose chase if you're not really focused on the questions and really understanding what's important. So here's an analytic model, which we now use as a standard framework. So the first thing that would happen once the topic is surfaced is a small group would actually develop the analytic model. And the analytic model, it looks trivial, but it isn't. And every condition has a somewhat different model and somewhat different issues involved. But this is a sort of this model actually starts, this says persons at risk here. And that may be average or that may be high-risk people, in which case you have to define how you get to high risk. And then there's a process of screening that leads to an early detection of a target condition, obviously, leading to a treatment, which may or may not lead to an intermediate outcome, leading to then reduced morbidity and mortality. We also are very mindful to look at adverse effects, because again, it's all about the balance. It's not good enough just to say that something's effective. And as you know, randomized trials rarely surface enough information about harms, so they end up having to look for other sources of data about harms. And that includes adverse effects of the screening process itself, as well as the adverse effects of the treatment. It's frequently in that area that we've got some of the biggest problems in the evidence gap, is really more around harms. Pharmaceutical industry does a great job around this area up here, and the FDA has less stringent requirements around this area down here. So when we think about the analytic framework, and the reason I've circled we think about these key questions that go along with it. Each one of these is itemized as a question, and always question one is, does the process of inviting people to be screened in fact lead to a direct net health benefit? And reduce morbidity and mortality? And that's kind of the obvious question. You'd like to kind of know, is there evidence to actually substantiate through a randomized trial of screening that in fact you can get there? You'd be amazed at actually how few topics actually have enough evidence for question one. Colorectal cancer is actually one area where we do have evidence for question one. In other words, when you randomly assign people to be screened or not screened, in fact, does it lead to reduction of colon cancer deaths? That would be kind of the gold standard for something we'd be looking for in terms of evidence. So that overarching question is, does the provision of service improve health outcomes if implemented in a primary care population? Again, unselected, more of a primary care orientation rather than a highly selected specialty population. And then an RCT, of course, would be the gold standard and a best evidence standard, in a representative asymptomatic population again. So that's what the first thing that the people at Oregon look for when they do evidence review. But in fact, rarely do they come up with very much. So then we end up having to dig down into the weeds.
What's RCT?
Randomized controlled trial. Sorry. So we end up getting actually into the weeds, and we look for something that we would call indirect evidence, meaning that we have to establish an evidence chain, knowing that if we get from A to B to C to D, and we have good evidence across that, then we can infer that in fact probably it does lead with some degree of confidence, and in fact that it does have some effect. But it is a bit of a skip logic. And in fact, but the questions are more numerous, as you can see. And so a lot more digging is needed. And in fact, all you need to do is fail in one of those chains to fail the whole process. So that indirect evidence recovery is frequently for researchers is a great opportunity, because you may have actually fairly intact chain except for one area, and which closure of that particular one area in fact could change the overall result. So those key questions that I highlighted are identified here. So can the population increase risk be identified? Does screening in fact lead to preclinical detection? Does the treatment of the screening detected disease lead to improvement in intermediate outcomes or in morbidity and mortality? And then finally, the harms 7 and 8 are important questions as well. So nothing can be taken for granted in these kinds of things, because just because we think that we're reducing cholesterol, do we think that we're definitely reducing mortality? Well, I think we all know we've been fooled before on a number of these questions, where we think that we're having a direct impact, but in fact we're having an indirect impact. So the importance of not making guesses and assumptions in this process can't be understated. Here's the lipid screening analytic model for children. I hope that you can see this, and it looks a little, is it okay? And as you can see here, the children and adolescents, you start with children and adolescents, and then you look at some screening procedure and be able to detect those kids with dyslipidemia. And of course, that's where we rely on you to be able to help us with that process. Based on that, there may be some adverse effects in that process, in the screening process itself. But based on that, we actually go and move into a treatment modality. All of which is to ultimately end up, and most of these studies actually look at intermediate outcomes because of the difficulty at looking at some of the long-term adult outcomes. So one of the problems in doing child evidence-based reviews is because frequently the gains or the benefits are so long-term that no one has ever done those trials, and no one will ever probably do those trials. You may have to gather the evidence from different ways. But ultimately what we'd like to do in this particular case is be able to draw a chain. Now I can assure you that, and I'll show you later, where the evidence was good and where it wasn't good. But this hopefully gives you an idea of what we're talking about. Now, the other area is that I point to health outcomes, morbidity and mortality, but increasingly we're looking at health outcomes also in terms of quality of life. So when you think about children in particular, it's not necessarily always about whether you die or not, but it may have to do with other features of your life. And for elderly people and for geriatrics, it's also an important issue, functional capacity and other things. So we broaden that kind of scope to think about than just morbidity and mortality, be thinking about quality of life, but even quality of life and quality of life as a final endpoint rather than just a so-called traditional health outcome. So the next steps in that process are to really, after the analytic model and the questions have been defined, are really to go find the evidence. And those three areas are actually outsourced mostly to the Oregon Practice Center. They're the ones that go do it. They're all, most of the people that are doing that work are physicians themselves, practicing physicians in that group. And they usually take about 6 to 8 months actually to do those reviews. They also help us evaluate the quality of those individual studies. We delegate that to them. We don't actually review the individual studies. And then they also help to synthesize and judge the overall strength of the available evidence, although the final decision on that comes by the small group that does it. So that work happens over a period of around 6 to 8 months, and there's frequent meetings with the stakeholders from the task force together with the people from the practice center to make sure that they're sitting on track. So part of that process to evaluate that literature that they're doing is what we call critical appraisal. So do the studies actually have the appropriate research design to answer the key questions? And so there's a whole evidence-based hierarchy around grading the evidence that's used, much of which has been developed by other bodies and we've adopted. And those studies are rated as individually in 3 categories, as good, fair, and poor. And then they're also looked at very carefully to the extent that they're generalizable to the U.S. population, because some of these studies are done in highly ungeneralizable populations by investigation groups that were not clear on whether or not this is really admissible, quote, it would be admissible evidence. So there's always that issue that's lingering in there as well. How many of those studies that have been conducted address those key questions? So the numbers of studies play into, obviously, the larger the body of evidence, the more confidence we have. And the size of those studies, what's the N and the number of people that are involved in those? How consistent and coherent are the results of the studies? Is there a lot of heterogeneity in those results? Or are they pretty much lining up in a similar fashion with similar relative risks or odds ratios? And then finally, are there other things that would help strengthen some of that causal model? And the usual things are around dose response, for example, or withdrawal in a population and what happens afterwards. Based on that, we then get an overall evidence report that we use to judge the strength of overall evidence. Those tables are really a work of art. They're phenomenally helpful. And then they also do meta-analyses. And so as you know, meta-analyses are where we combine numbers from multiple studies and recrunch the the combined relative risk based on the based on the total N from all of those studies together. So that group does that as well. Lately, the one thing that's new that we've started, which has been I think drawn some interest, is we've been using modeling. And particularly in cancer research, in colorectal cancer, the most recent recommendations were derived from models as well as evidence. So models being statistical models with many inputs from scientific studies that help us model out what we think the long-term trajectory of these people would be. And in fact, these models, having used the models used in breast cancer evaluation, are incredibly helpful to really and add a great deal of information. They're a little controversial because modeling has not exactly been part of the evidence-based process. But in fact, there are limits to what we know about in terms of our evidence, and the ability to know that we'll ever get that evidence is definitely sometimes unclear. We also obviously rely on systematic reviews from other sources like the Cochrane Collaborative, which hopefully you may have heard of. So based on that, we kind of give the overall body of evidence, all those studies together, kind of 3 different grades. We decide that the evidence is convincing, meaning that it's based on well-designed, well-conducted studies in representative populations that directly assess effects on health outcomes. Or we say it's adequate evidence, meaning that it's sufficient, but limited by the number and the quality or the consistency of the studies, the generalizability to routine practice, or the indirect nature of the evidence, meaning it's good, but there's some questions that still could be improved in the literature. It's hard to get convincing evidence any better than convincing. So we generally, those ones are likely to change in recommendations, but those that are deemed adequate may change. And then there's inadequate, and clearly, and that's some of the biggest problem that we have, is the insufficient evidence really to understand, based on the limited number or power of studies, important flaws in the design of the way the studies were conducted, gaps in the chain of evidence, so we don't have full gaps across, or that there's lack of information about health outcomes. We may get great studies looking at effects of drugs on lipids, but we may not know anything about what happens to those people beyond just their lipid values. And in fact, pediatric lipid screening, and the reason it turned out to be an insufficient evidence recommendation, it was given an I grade, and I'll talk more about that in a bit, was precisely because it actually suffered from all of those problems. It really didn't meet the grade on any of those issues, really posing a vexing problem there. And I'll come back to that. And right here, as you can see in the analytic model, the areas that I circled as green are areas in which we basically did have reasonable evidence that in fact I would say either moderate or adequate or convincing evidence. But overall, we had important gaps. And as I mentioned earlier, this says reduced incidence of adult dyslipidemia. This is the biggest barrier right here, is we don't really understand the significance of lipid values in children. We don't really understand what their long-term implications or what their trajectory are. There's no evidence on that. And so without that, it's really hard to be able to make an assessment about what the effect of lipid screening would be down the road in adult health outcomes. Is it good enough to say that we should recommend lipid screening because we know it can reduce triglycerides or LDL? No. I think that we would say that doesn't really, is not tantamount to a health outcome. And it would be shaky to call it a proxy for a health outcome. We also had no evidence on harm. We have very little evidence on harms because most of the trials done in dyslipidemia are done in children with familial disorders. They're highly selected populations and not in primary care. Very little in just the obese children. So we really didn't know much about what the effects of screening, although we thought these were probably small. But the bigger question is, what's the effects of the treatment in children long term? You know, when you put a child on a statin for life or for 30 years, do we really know what we're going to do in that situation? And I think the honest answer was no. We obviously didn't have any data that would answer the a priori question, which would be a 30-year trial at least. And so we were left with this, essentially lots of gaps. So based on that, we have to make a decision about balance of benefit and harm and the certainty of that net benefit. So the likelihood that the assessment of the net, that we define that the net benefit is really defined as benefit minus harm as implemented in primary care population, and that we base a certainty level based on the overall evidence, not just for each of those questions, but for the whole picture. How much certainty do we have about the whole picture? And that we would say that we have fairly high certainty, not surprisingly, we have consistent studies, well designed, well conducted, and this is starting to sound familiar to you, that when we extrapolate at a study individual level up to a higher level, we would expect these things to be happening in order for us to have a high level of certainty. The other thing I want to point out is that that when you have high certainty, it's unlikely to be affected in the future by other studies. In other words, the evidence is so overwhelmingly strong that it's very unlikely that a study is going to come around and actually shake something down. And that's one reason that once you reach an A recommendation by the task force, it never has gone from an A down. It only, there are other ones that move, but this one's not one of them. A is not one that will move. And again, moderate follows along the adequate evidence line, which is that there's some issues here that are outstanding, that are of concern, including the number, size, or quality of the studies, as well as the inconsistency and generalizability. This may change, and as our certainty can get higher, and it is possible that a recommendation could get stronger as more evidence accumulates. When our level of certainty is low, as it was with pediatric lipid screening, it's because of the same reasons we just talked about. And in fact, that these are ideal research questions and allow for an invitation for research, because in many cases these are ones that could move either way. They could move to services that aren't recommended, or they could move to services that in fact should be recommended. So prostate cancer screening, you guys know, is an I, insufficient evidence, incredibly controversial. Was reaffirmed again by the task force, still insufficient evidence around prostate cancer screening. It's not, and the whole issue of I, which I'll talk about more in a bit, is really around that we just don't simply have enough of that stuff filled in order to be able to say for sure. So the balance issue about harms, I think that the issue of harms is really, they're real, but they're hard to quantify. And as you know, better than anyone else, issues of false positive tests are a significant issue, as well as false negatives. We have issues with labeling around screening, people who are identified as having disease that may not have disease. And then we have overdiagnosis, which is a particular problem, say, for example, in cancer, where we identify people who have cancer for which their tumor actually, it's unclear that identifying the tumor, the significance of that tumor, in fact, is unclear from a clinical or pathologic standpoint. And increasingly in breast cancer and prostate cancer, these questions are being asked more and more. We have opportunity costs around, well, if you do this screening, you're not doing something else. If you spend this dollar instead on something else, that's a potential harm. And then it is kind of hard. It's subjective to some degree, because how do you compare, say, for example, the pain associated with having a prostate biopsy with a potential, with comparing a harm to a benefit isn't always equivalent, and it's not necessarily easy to do. We do have some numbers that we can use, number needed to harm, meaning how many people do you screen before you get a harm, that we routinely would calculate and look at. And those numbers are all over the place. As you know, number needed to harm can be quite low, and it can be very, very high. In lipid screening in children, it's actually probably in the hundreds, as best we can tell. The same thing with magnitude of net benefit, because there's no explicit criteria for measuring magnitude there. We use number needed to screen. So how many people do you need to screen in order to save, for example, to avert or to save a life? And those numbers can be, as in breast cancer, in the high 1,000, 1,800 range, or they can be very low. But we do look at that number because, or newborn screening, for example, it's in the tens of thousands or hundreds of thousands. But number needed to screen is something we would sort of keep an eye on. Inevitably, what we talk about in terms of net benefits, we categorize it as substantial, moderate, or small. So benefits minus harm equal net benefit, and then finally what we do is we link, basically that leads to a grade. So this is a key table I just want you to look at real quick, because this is a table that sits up at the task force meetings that you stare at frequently. And because what we do is, after coming to this decision about the certainty of the net benefit, and after you decide the magnitude of net benefit, essentially if you know those two things, and the grade is made up for you. You don't just come up with the grade out of your head. You have to decide what's the certainty of that net benefit. And again, I have to emphasize net, take into consideration harm. And then also, what's the magnitude of that net benefit? And if you start off with the certainty being low, I mean, we just don't have much evidence to say one way or the other. You don't have to really think about the magnitude, right? Because you don't have enough information. In which case, we would call that an I statement, or insufficient evidence. And I'll show you a bunch of the I statements that currently exist. If, on the other hand, your certainty is high, and you have substantial or moderate net benefit, you're falling somewhere into the A or B range. In fact, A could only get there by having high certainty and substantial net benefit. There are not a lot of A recommendations. And I showed you some of those just a little bit ago. And then on the other scale, we don't talk enough about the Ds. And the Ds are recommend against use, meaning that we know enough to know that, in fact, the net balance is harmful. We shouldn't be doing these things to people. And you'd say, well, why do we, no one's doing them anyway. And the answer to that is not true. That D recommendations, in fact, do show. And one of the challenges, I think, for people in laboratory medicine, for example, and other parts in radiology and other areas that are doing these, actually doing the tests, is, in fact, do your own inventory and audit about how much of this activity is happening. C is a tricky one, and C is where the magnitude of the net benefit is perceived to be small, and the certainty is high or moderate. And small enough to know that probably not worth doing on a routine basis, but consider it an individual patient. There are not a lot of C recommendations, and I'll show you some of those in just a little bit. So this is the narrative, the way the narrative goes. And all these words are words I just shared with you right now. They have those words about certainty, net, and substantial. They're all these same words, in fact, are there. But the other way to think about, the simple way to think about it, thanks to my colleague Tom DeWitt, who's on the task force, is to think about it: do, don't know. Do is A and B. You don't have to really worry about A versus B. It's not a big deal. Don't do is a D for sure, and a C, don't do routinely. And an I is we don't know. And an I is not a recommendation, it's a statement. It's just basically a statement of fact. We don't know. Use your best judgment. Discuss it with the patient. Use shared decision making to decide what's appropriate, giving them the pros and the cons and what we know, like in prostate cancer, which is advocated for prostate cancer screening. So that I statement is, as I said, is a conclusion, not a recommendation, and it really represents that call for research. And I think most of these other things I've already emphasized already. Well, then the question comes, okay, that's great that you recommended something, but then the doc wants to know, well, okay, that's the first question. That's easy. Okay, that's great. But then, how often should I do that? How often do I need to do the colonoscopy or do fecal occult blood screening? How often do I need to be screening women for chlamydia who are between 16 and 25? So those questions are dealt with in a separate section of the clinical considerations document. And frequently we have to acknowledge that we don't have data on some of those things. That will not keep us from making a recommendation or not, but sometimes those details are fuzzy. And that's where my role at group health comes in, because ultimately we take that recommendation and then we have to, it's a raw sculpture, and we've got to chisel it down to actually to move it down further. So the issues around how do you assess risk, the screening tests that are used, these things are usually outlined in the document, but frequently we may not have information about screening interval. Because in fact there wasn't a subject investigation. So as I showed you earlier, those are the A and B recommendations for non-pregnant adults. And the yellow are lab tests, as you can see. Now when I show you lipid disorders, I'm showing you that's for adults, not for children, right? So that's an A. Colorectal cancer being an A, and cervical cancer. Cervical cancer is one of the unique ones that never had a randomized trial associated with it, actually. And the evidence there is all based on overwhelming prepondering population-based evidence that implementation of screening programs leads to vastly decreased rates of cervical cancer. It's a very unique one that got an A based on that. But almost everything else is buttressed by randomized controlled trials as the primary source of information. But what about recommendations for high-risk adults? Now, these are people that meet certain risk criteria. They can't just be any old person that comes into primary care. These are people who have to meet some criteria. So for abdominal aortic aneurysms, it's men who have ever smoked between 65 and 75. Very specific, very narrow. That gets a grade B recommendation. Screening for type 2 diabetes falls only for people who have hypertension. We don't recommend routine screening for average people for diabetes. There's no evidence to suggest that, in fact, the net benefits are greater than the overall, that are greater than are substantial or moderate. And many of these other, I think, are familiar to you. All of these people have to meet some kind of prior criteria in order to get into this list. And then there's the Ds. Again, highlighted in yellow are the screening ones that relate to laboratory medicine, but there's lots of Ds. Ovarian cancer recently was revisited again, and we just don't have the evidence to be able to support that, in fact, you're doing more harm than, that you're doing more good than harm. In fact, in this case, we're looking at more harm in this. But in fact, many of these Ds are thought probably never to move out of the D range. The I statements are more problematic for clinicians because many clinicians don't know really how to use that I statement. Prostate cancer being one of the most, obviously the most controversial ones. Lung cancer generating a lot of press recently through lung cancer CT scanning as an early way to detect lung tumors. Again, unproven as of yet. And then a lot of things which to the average lay public may seem to be, what? Are you kidding me? I thought that was routinely recommended. And in part because they are promoted routinely by many people. And in part, has not necessarily stopped people from implementing these on a regular basis. And some of these can be extremely controversial. Domestic intimate partner violence can be an extremely controversial one where it seems like a no-brainer to screen routinely for domestic violence. But the reality is we don't know enough about the harm of screening, and we certainly know that the level of harm associated with intimate partner violence can be considerable, to really assure ourselves that, in fact, the process of screening is safe enough. These represent sort of the I statements for average risk. And then the I statements for high-risk people are also there as well. So, for example, chlamydia screening in men, high-risk sexual activity in men, we don't have enough information to say one way or the other way we should be screening or not. And then the C recommendations, which I mentioned to you, are ones that for which the net benefit is small, include these here. So lipid screening in younger adults. Not done in a fair number of practices, but in fact, we would say should not be done routinely, should not be screening everyone. Chlamydia infection for low-risk women as opposed to high-risk women, and then obviously HIV screening for low-risk adults. You know very well that the CDC and the task force came out of major disagreement over the HIV screening issue and had a very significant disagreement about it, just like we had a significant disagreement with the American Academy of Pediatrics about lipid screening, which they recommended, and we said no, insufficient evidence. So the pros of the process are really about creating recommendations that are based on evidence through a transparent, explicit process, which I tried to lay out to you today, and that also protects against influence of politics, economics, and advocacy, which frequently professional societies are subject to in a big, big way. So we basically lay all our guns on the table, have to say what weapons we're carrying. They get all pushed off the table. People have to recuse themselves even if they have an intellectual conflict of interest, meaning that they do a lot of research in this area and they say, you know, honestly, my mind could not be changed because I'm so into this. So they will excuse themselves from the conversation. And it's a very, very rigorous process of recusal. We think that providing primary care clinicians with standardized recommendations really can, really lead to the improvement in health of their patients, and also for purchasers, and also for they're using the direct audience with patients as well. The challenges are partly these. The I is one of our most common recommendations, but clinicians are really flummoxed by the I. We don't have great systematic consideration of patient values in this process. So it's really understanding where the patient comes in, and that the idea of shared decision making then should be brought in as that is, particularly in eyes. We do generate some data on cost effectiveness, but not systematically, not aggressively, in part because the government's very shy about doing that. And the process is expensive and really time consuming. And it doesn't offer answer to these questions that I mentioned earlier before. There are reasons for conflicting recommendations between organizations and societies, and these are some of them right here. The Academy, it was clearly, the Academy around lipid screening used a very different process. It used expert consensus model. They weren't systematic in their literature approach. And they, I think, made a number of assumptions along that process that led to that ultimate consideration. The task force process frustrates many clinicians, in part because they feel that it's too conservative. And that's part of that approach to uncertainty that's difficult, is that trade-off of being wrong and adopting the service before the benefit is proven, in which case if you take the gamble and you're right, you're a hero. But if you take the gamble and you're wrong, you might have hurt many people and killed many people in the process. And having seen what's happened in the world of drugs, particularly with regard to anti-inflammatories and other drugs, recognizing that really the gravidity of that process really gives pause to thinking about how quick should we really be. Finally, I just want to say about integration of payment, of so I said at the beginning, guidelines are great, no one pays attention to them. The UW put forward a bunch of guidelines on their website and stopped doing it after a while because no one was really looking at them. And guidelines are increasingly one of the, how do you actually make them so that they're useful? Well, one is through decision support, by making them available at the time that the service is done, and making sure that those that are providing the service also have access to that information. Second is to actually impose policy around payment and also make it sort of effectively have teeth. So Medicare now will no longer pay for a D service that's not recommended is not to be done by the task force. Medicare will no longer be paying for as of this year. Performance scoring, HEDIS scores are done by HEDIS. HEDIS gets most of their ideas from the task force. In fact, most of the HEDIS measures are direct translations of task force recommendations. So health plans and docs all over the place are trying to compete to improve their quality scores for many reasons, pay for performance and other reasons. And in fact, they are competing on the basis of task force recommendations in many cases. The Health Alliance, like Puget Sound Health Alliance here, grades doctors' groups, and they're using task force measures as well. And then finally, large purchasers who are gaining increasing clout and who buy the health care and pay for it and are fed up with how much money they're spending are actually looking to groups like the task force to help define what is evidence-based. I want to conclude, this is my last slide, about just some reflections about what the implications of all this would be for healthcare reform. As I told you at the beginning, I think that evidence-based medicine's been around a long time. It hasn't quite found its mainstream in American medicine, and I could be off, but I think that there's a good opportunity in this next administration. You know that healthcare costs are a major driver of poor access. The reason we have uninsured people is because we cost too much. Every time we raise our rates at group health, we force people out, and so does every other insurer. So our task is to make healthcare cheaper. And to make it more accessible, we have to make it cheaper. We have to figure out a different way of doing it and financing it for sure. The biggest opportunity to improve quality and reduce the costs of care are really by reducing ineffective and erroneous care and not necessary care. Do less. Because as I told you at the beginning, preventing doesn't save necessarily very much money. But doing less can save a lot of money, and maximizing the uptake of effective care to keep people from getting complications is another way. So these kinds of guidelines and recommendations can help guide the practice of medicine, and the task force is an example of how that might be done in the future. And lab medicine, finally, I think has an absolutely key role in supporting this. And in our lab at Group Health, Kim Riddell is fabulous in being able to help support what we do by providing data all the time, looking at us being able to look at ordering behavior of clinicians and understand, practice those ordering behaviors, and then providing feedback on a regular basis as well. If you have further questions or interest in the topic further, you can look at those websites there, and I'll provide you with additional information. And I thank you very much.
Questions for Dr. Grossman, Dan? I have a question that's sort of like in a way the opposite of evidence-based
medicine, and that is, we're getting more and more into the era of personalized medicine potentially, where people's genotypes might give them an idiosyncratic response to whatever intervention you want to take. So obviously you can't get large studies of people with certain genotypes. So what do you do in this area? How do you approach
Well,
this?
you put your nail on that, like the hottest topic there is, and I ducked it. The question is really around what are we going to do about, particularly around personalized medicine. And does personalized medicine mean, does patient-centered care mean that we have to, when people request things, that we have to give it to them automatically? Is that what we're going to? No. And I would say the answer is no. Personalized genomics poses genomic screening is a huge challenge, and we're not entirely clear how we're going to deal with these issues. And you point out very appropriate things, which is, are the studies really ever going to be done and on very highly specific populations? And on top of that, I think that we're all starting to kind of sift and dig and understand what that means, assuming we get there. And I think I'm among the group that feels like we're still a ways away from getting anywhere there seriously. But a lot of this will also be partly dependent on the cost of the technology themselves. Clearly, I know you guys are involved in some genetic screening evaluations as well, and there's all sorts of variety of high quality, low quality stuff out there. But I think this is one of the single biggest challenges in the field of screening that there are. Other questions?
So you were very clear to articulate the difference between absence of evidence and evidence of absence.
Yes.
But you also mentioned that the I category flummoxes healthcare workers. So
yeah.
You mentioned the incoming administration. So I'm curious how the task force is going to safeguard the task force from causing harm, which is if a political appointee decides that the A and B categories are great, the D is great, but what if C and I end up in the D category?
I think we would not support that. I don't think I see much evidence of that happening, or any even hint of that happening, honestly. What we're doing is appealing to NIH and saying, you guys spend a lot of money on research, and here's some very hard, concrete areas that investment would lead to some really important answers. Could you maybe make an RFA on that topic? Attract a little competition and interest in the topic. And in some cases, these aren't huge. They might involve actually secondary analysis of very large data banks to look at harms, for example. Much in the way FDA went and combed Kaiser's database looking for harms around Vioxx. There are some of these questions, I don't mean to, around lipid screening in children, there are some really daunting challenges associated here that we may not be able to answer for a long time. But some of them we should be able to. A randomized screening around domestic violence in women, for example, that's within reach.